The room smells before you see it. Dried blood and sawdust and something underneath both that you cannot name and will not forget. You are standing in a surgical theater in London, 1840, and the man on the table is still awake. That is what happened inside the room before anesthesia existed. And by the end of this, you will understand exactly what that meant for his body, and why the people doing it to him were not monsters. They were the best medicine the world had ever produced. Picture the theater first, not a room, a theater. Tiered wooden benches rising in a steep circle around a central table, packed with medical students, visiting surgeons, the merely curious. Daylight through high windows, because gas lamps throw the wrong shadows and you cannot cut what you cannot see clearly. The floor beneath the table is covered in sawdust to catch what falls. The tools are laid out on a side cloth. Knives, retractors, bone saws, a tourniquet already tightened on the limb. The smell of the sawdust mixing with the older smell soaked into the wood of the benches themselves. Years of it, a residue that no amount of airing out ever fully solves. The patient is awake. That is the fact that everything else organizes itself around. He has heard what is about to happen. He has been told to hold still. He has been given what the century had available, which was almost nothing by the measure of what was about to be asked of him. Alcohol, sometimes. Enough to dull the edge of fear. Not enough to dull the edge of a knife. Opium, in some cases, which quiets the mind toward a heavy fog but does not stop the signals the body sends that instant tissue separates from tissue. It blunts. It does not erase. The man on the table knows this. He has known it since he agreed to be here, and agreeing was itself a calculation, because the alternative to the table was often the thing that made the table necessary in the first place. Gangrene, a tumor growing past any other remedy, a bone shattered beyond the body's ability to knit it back, so he lies down, and the assistants take hold of him, not gently, not roughly either, just with the complete and practiced certainty of people who have done this before and know what is coming. One at the shoulders, one at the legs, sometimes a third across the torso. Their job is not to comfort him. Their job is to ensure that he does not move at the moment. Movement would be most catastrophic, which is the moment the surgeon is deepest inside him. An involuntary flinch at the wrong instant does not simply hurt. It kills, and the surgeon has to be fast. This is where Robert Liston enters the room, and the room changes when he does. Liston operated at University College Hospital in London in the 1840s, and his reputation was built on a single quality that his era treated as the highest surgical virtue: speed. He could amputate a leg at the thigh in under 30 seconds, start to finish, and the figure was not legend, it was witnessed, recorded, measured. In a world with no anesthesia, the duration of the operation was the only mercy a surgeon could reliably offer. Every second on the table was a second of full conscious experience. So the fastest hands in the room were the kindest hands in the room. That is not a paradox. That is how the arithmetic worked. The incision happens. You feel the pull of it before the pain arrives, a deep tug as the blade moves through skin and into the layer beneath, and then the pain is there, complete and total. Nothing theoretical about it. The body does not distinguish between the blade of a surgeon and the blade of anything else. It sends the same signal, and the signal is loud. Patients screamed, not as failure, not as weakness, as simple biology. The nervous system reporting accurately on what is occurring. The assistants lean harder. The surgeon does not pause, because pausing is the one thing that makes this longer, and longer is the one thing that makes this worse. The bone saw follows the knife in an amputation. The sound of it is specific and does not resemble anything you have heard in a quieter life. The blood is more than you imagined and less than kills you, usually, if the tourniquet is doing its work. The assistants talk to the man on the table sometimes, not instructions, just voices, the way you might keep someone company in a dark place with no exit. The surgeon counts nothing. He just moves. The whole room is watching. That is the part that settles strangely once you know it. The tiered benches full of observers, the notebooks open, the careful eyes tracking every movement of the hands. They are learning. The theater was built so that suffering could be studied into usefulness, so that the next patient might spend fewer seconds on the table or survive what the last one did not. That was the logic the room was built around. Not cruelty, calculation. And the calculation had limits nobody in that room could yet see past. Beyond the leg, there were worse rooms. Lithotomy, the cutting for stone. Bladder stones large enough to obstruct, to poison the blood slowly, to make every hour of living a negotiation with agony. The procedure required a man to be folded into a position so extreme it had its own name. The lithotomy position, knees drawn up and out, the body open from below. Jacques Beaulieu, A French itinerant surgeon working in the late 17th century could complete the cut and the extraction in under 2 minutes. He performed it hundreds of times across Europe, often on children, because stones collect early and the body does not wait for a more convenient century. 2 minutes was the mercy. What those 2 minutes contained, you already understand. Battlefield surgery was a different arithmetic entirely. At Waterloo, in June of 1815, the field hospitals processed thousands of men in the hours after the fighting stopped. Dominique Jean Larrey, Napoleon's chief surgeon, was recorded amputating at a rate that contemporaries described as mechanical, not as insult, but as observation. The limb had to come off before shock deepened, past recovery, before infection colonized the wound, before the window closed. So it came off fast, in firelight, on a door laid across 2 barrels, with men waiting in line outside who could hear what was happening inside. Speed was not barbarism. Speed was the only variable the surgeon could actually control. Which brings you to the limits. Not every operation was attempted. That is the part that gets lost when we picture the pre-anesthetic world as simply willing to cut anything. It wasn't. The abdomen was largely untouched. Entering the chest was almost always fatal. Operations on the eye existed but were narrow and specific. The calculus was not, can this be done, but can this be done fast enough? And will the shock of doing it kill the patient before the procedure saves them? Pain itself was a lethal variable. Deep enough, prolonged enough, it tips the body into a spiral the heart cannot climb back out of. Surgeons knew this not because they had the neuroscience, but because they had the bodies. They watched men die on the table from operations that were technically successful. The procedure worked. The patient did not survive the procedure, so you did not attempt what you could not finish quickly. The unopened abdomen was not ignorance. It was a decision made by people who understood their own arithmetic, speed, force, restraint. They were not cruelty dressed up as technique. They were technique, precise responses to a problem set that had no other solutions yet. The assistants held the patient hard because a flinch at the wrong depth was fatal. The surgeon moved fast because duration was directly convertible into suffering and shock. The tools were heavy and decisive because hesitant cuts caused more damage than clean ones. Every feature of that room that looks brutal from outside, it was logical from inside it. Then Boston, October 16th, 1846. Massachusetts General Hospital, the room they would later call the Ether Dome. A dentist named William Morton administered sulfuric ether to a patient named Edward Abbott, and the surgeon, John Collins Warren, removed a tumor from Abbott's neck while Abbott lay still and silent. When it was over, Warren turned to the gallery and said something that various sources record, with slight differences, but whose meaning was unambiguous. The thing they had all accepted as an unalterable condition of surgery had just been altered. The patient had felt nothing. The room had been, for the first time, quiet. The news moved fast. Within months, ether was in use in London, Paris, across Europe. The operation changed overnight. The screaming stopped. The assistants relaxed their grip. Surgeons could take longer, be more careful, go deeper. Procedures that had been considered impossible because no conscious patient could survive the duration became thinkable. The table was transformed, but the room was not yet safe. Anesthesia solved pain in 1846. Infection remained unsolved for another 2 decades. Joseph Lister's antiseptic methods, built on Pasteur's germ theory, began arriving in the late 1860s, which means there was a gap, a period in which the patient felt nothing, and so the surgeon could operate longer and more ambitiously, could open the abdomen, could attempt what had been previously impossible, and the wound still closed over whatever the instruments had carried into it. The room became quieter before it became survivable. Patients went under peacefully and died days later from what the air and the unwashed hands had left behind. The mercy of unconsciousness arrived before the understanding that had to accompany it. Anesthesia without antisepsis was not salvation. It was a quieter version of the same problem. The surgeons in the Ether Dome were not stupid. They were exactly as brilliant as the room they were standing in, and the room had one wall still missing. Now come back to the man on the table in London, 1840. The one from the beginning, the sawdust on the floor, the tiered benches, the assistants with their practiced, certain hands. He is not a specimen of barbarism. He is the most expensive product of everything medicine had managed to learn up to the moment he lay down. Every fast hand in that room had been trained by suffering, turned into knowledge. Every tool was the result of someone asking how to make this less lethal than it was last time. The system was not cruel. It was incomplete. There is a difference. And it matters because incomplete can be finished. Your body still carries the memory of that table, not as trauma, but as architecture. The flinch response when something approaches your skin without warning. The way your whole system goes alert the instant something sharp touches you in an unexpected place. Those responses were calibrated in rooms exactly like that one, across generations that survived by reading the signals their bodies sent them and acting on what they found. Surgery got quieter, then it got cleaner, then it got so precise the room barely resembles the one where it started. But it started there, with a man who chose the table over the alternative and people who moved as fast as they could to deserve that choice.